Okay, everyone. I think we're going to go ahead and get started. On behalf of all of us here at Medical Advantage Group and SIPA, I'd like to welcome you to the latest of our behavioral health webinar series. Today, we're joined by Dr. Mason and Richard May to talk about the algorithm and protocol for the treatment of anxiety. Before we get started, I wanted to cover a couple of housekeeping things. First is that all the phone lines are going to be muted during the presentation today. We are going to pause at the end, though, to take some questions. So as you think of questions, please just enter them using your GoToWebinar control panel. We'll pause towards the end and address those. And then, as always, after our session today, all registrants will receive a copy of the materials as well as a recording of our presentation today. So before I turn it over to Richard, let me just do some brief introductions. Richard May, MBA, President, Strategic Integration Solutions. Richard has over 35 years of executive management and administration experience in the areas of behavioral health, acute care hospitals, and outpatient rehabilitation. Over his career, Richard has held C-level positions, including Chief Financial Officer, Chief Operating Officer, and Chief Executive Officer. Currently, Richard is the founder and president of Strategic Integration Solutions, a healthcare consulting firm that focuses on providing organizations with a clinically integrated patient care system. This includes the integration of behavioral health and other clinical service lines with primary care. We're also joined by Dr. Mason once again. Dr. Mason is a clinical psychiatrist in practice over 30 years. He specializes in work with EMTs and firemen and also does extensive work with adolescents. For many years, he's done consulting work, often together with our very own Richard May. So with that, Richard, I'll turn it over to you.
Thanks so much, Bill. Good afternoon, everyone. Thank you for taking time out of your schedule to attend this webinar session. We've been very privileged to do a series of these presentations for Medical Advantage Group, beginning with the interrelatedness of behavioral health and primary care, and then moving on to depression, and now we're talking about anxiety. So if you've attended those sessions previously, you'll see that we're progressing through the process of integrating behavioral health into primary care practices. And that's one of the things I have the privilege of working on with Medical Advantage Group. So may I have the next slide, please? We can see that primary care practices are and have been becoming a medical home, not only for acute and chronic care physical health issues, but for mental health issues. The majority of physicians and providers that I work with and communicate with indicate that at least 50 to 60% of their patients have a presenting mental health issue. So there's a vast amount of information that speaks to the need to integrate behavioral health, and it's really picking up momentum at the end of 2016 and now into 2017. I see so much more being publicized, even an article in the Saturday edition of the Wall Street Journal mentioned how there is a profound need to integrate more comprehensive care that includes behavioral health with primary care. So we can see that there is a much higher cost to our healthcare system associated with individuals that have both a mental illness and physical health conditions. Next slide, please. So what we're going to try to look at briefly today is focusing again on the relationship between mental illness and physical health. And we're going to hone in on gaining a better understanding of the relationship and impact of anxiety on individuals with chronic physical health conditions. And then Dr. Mason will be presenting the treatment protocols that can be instituted at your practice to deal with patients that are diagnosed with anxiety. What you'll see in these slides is we provided a lot of narrative information to the point where we're not going to read those word for word, but when Medical Advantage Group sends you that material, those narratives and comprehensive in detail will give you an additional library source, if you will, in addition to what we presented in the first two webinars, to learn more about the effects of anxiety and how it impacts what you do in your practices. Next slide, please. And the next slide. It's been reported, as you can see, that a large percentage of people with mental illness are going undiagnosed and untreated. But what's really profound is that at least 50% or more of those that are diagnosed are going to deal with that condition for the rest of their life. And that is a really startling statistic when you think about the patients that are in your practices today, that not only may they have an undiagnosed and untreated mental illness, but when you do uncover that disease could linger with them for a long, long time. And as I said, a week or so ago, we did a presentation on depression, because depression and depression screening is receiving a lot of publications and presentations today, and rightly so. It does impact the clinical quality outcomes, and it does impact the total cost of care, as we saw in that presentation. However, a lot of studies that I've seen lately indicate that anxiety could be more prevalent in your patient population than is depression. Next slide, please. A lot of our utilization of the emergency room is predicated and caused by this underlying symptomology of mental illness, including depression and anxiety. It's not because they're not trying to be compliant with their primary care plan and adhering to their medication regimen. Instead, their socioeconomic and mental health issues may be so overwhelming and profound that it really serves to exacerbate their physical health condition, and therefore they have a flare-up of their disease and wind up going to the emergency room. And here's an example on this slide of a patient that you may have in your practice that has Crohn's disease, and arrives at the emergency room with severe abdominal pain. The focus is going to be, how do we alleviate that pain as quickly as possible to make the patient comfortable? While we'll make some effort in the emergency room to see what may have caused this flare-up, then we'll move on to alleviating that painful condition. Next slide, please. However, many times, whether it's in the emergency room or in the medical office, consideration is not given to discovering the root cause that was behind that flare-up. It could be a serious condition of anxiety related to their workload, the pressures at work, and relationships in their home life, and other factors as well. So what we're presented with is super utilizers that continue to hit the emergency room, driving up the total cost of care, when medical treatment alone may not keep that patient from returning to the emergency room. But when we take an integrated approach to providing health care and thinking about how we can improve clinical quality outcomes and reducing the total cost of care, we may want to consider the appropriate interventions that include consultation with having a behavioral health specialist on site in your primary care practice, which is a practice that's occurring throughout the country, and one that we're working on with Medical Advantage Group and some of the SIPA practices. Next slide, please. I put this slide in here intentionally because it gives me an occasion to describe what has motivated me over the last 10 or 15 years to pursue this integration of behavioral health with primary care. We have practices on the line today participating in this webinar that represent thousands of patients. And each day, those practices have to face the reality of presenting those patients with some very tough diagnostic results. And I recall about 10 or 12 years ago when I was executive director of a neuroscience center, a joint venture between two hospitals in Lima. My office was next to the neurosurgeon's office. And I had my door open often. And when I heard the physician meeting with one of the patients, and I heard the sobbing, the hysteria of that patient that had just been given the news they were diagnosed with brain cancer and left with their family members shaken, overwrought, I went to the neurosurgeon and asked, what do we do in situations like that? How can that patient possibly consider their plan of care and even sleep regularly? And the response prompted me to go down the road that I'm pursuing today with Medical Advantage Group and elsewhere to integrate behavioral health with primary care and even specialists. With the example that I just gave you, the patient at some point and their family members should be given the opportunity to complete the screening instruments that Dr. Mason will refer to in a few minutes. But even with your patients that don't have that profound experience and diagnosis that I just referred to, there could be underlying reasons why they're really at your office. Yes, they have a presenting physical problem, but what caused that issue to flare up to lead them into your office? Those are some questions that we really need to think about. I would suggest that if we were to stratify your patients into disease registries with using the 3 highest by volume diseases, that hypertension would be among the top 3, probably along with diabetes, maybe COPD and CHF. Well, let's look at hypertension. Vast number of your patients are living with that disease and may for the rest of their life. Well, what's the cause of the hypertension? Well, initially we may say bad diet, eating habits, drinking, whatever they consume, smoking, but why? Why are they not wanting to manage their health better in order to get off that medication regimen? And that, I suggest to you, is an opportunity to use the screening tools that we'll be addressing here in a few minutes. Next slide, please. Here is an opportunity for me to move the presentation over to Dr. Mason by I took some of these types of anxiety disorders out of a very recent article that I found extremely interesting on how the integration of behavioral health and using the PHQ-9 and GAD-7 screening tools had a very significant impact on improving compliance with primary care plans and reducing the cost of care for each one of these types of anxiety disorders that I put on the screen. And I'll leave you with this thought and come back at the summary after Dr. Mason has completed his section. But I'll leave you with this thought. You know, we live in a world today much different than what I grew up in. Fear and stress seem to be the norm. And the reality is that when Dr. Mason and I were working on opening an inpatient psychiatric hospital about 5 or 6 years ago, I was asked by the Ohio Department of Mental Health to admit children as young as 4 years old due to being on psychotropic medication for stress, anxiety, and depression. And I found that a startling revelation, but yet mirroring the world that we live in today. So as I pause and turn this over to Dr. Mason, I'd like for those of you that are participating in the webinar from a physician practice, a primary care practice, to think about how you can take steps on improving clinical quality outcomes and reducing the total cost of care by taking a few minutes in your schedule to use the screening tools that we're referencing next. So with that, I'll turn it over to Dr. Mason.
Well, thank you, Richard. I'm going to spend some time talking about anxiety disorders. Let me have the next slide, please. And we look at anxiety disorders and see them quite often. Like depression, anxiety is a normal human emotional response to situations. You could basically see it as, and actually it is, seen as a survival emotion. Basically, it involves the generation of fear that may or may not be specific in nature, and actually it's usually a generalized fear. And you've heard the flight or fight reaction, I'm sure, before, and that is basically the kind of behaviors that you see in an anxiety reaction. I think we're seeing an increase in anxiety over depression simply because of the chaos that we're seeing in the world today. As Richard mentioned, you know, when we were growing up, I don't think we had half the chaos that we had now. But the only thing that gave us a lot of anxiety was somebody dropping a bomb on our head when we weren't expecting it. But beyond that, life was fairly uncomplicated. Now it's become a lot more complicated, a lot more competitive, and the speed of getting bad news is probably quadrupled over the last 20, 25 years, which is going to have an impact on how people react and how they manage their lives. Anxiety comes in a number of different forms. Sometimes it may appear as a major syndrome, but it also can appear as a personality disorder. For example, the obsessive compulsive disorder that Richard had up on the screen a couple slides ago is typical of a personality disorder that is generated by anxiety. People who are obsessive compulsive are that way because they feel like they're out of control of their lives, and the way to deal with that is to become overly obsessive and compulsive about the way they do things. For clarification, obsessive or obsessions are thoughts. Compulsive or compulsivity is behavior. So I've had a couple patients who compulsively counted numbers as a way of assuaging their anxiety. I've had others, and you probably have too, that constantly wash their hands. They're carrying a Purex around, and I've had a couple patients that have washed their hands so much they actually cause them to bleed because they're afraid of getting some weird illness. You know, obsessed people. For example, I had one yesterday. The woman's obsession was that she is afraid that she's going to develop type 2 diabetes. Well, on the rational side, there may be some cause for concern because diabetes runs pretty strong in her family. However, she does not have type 2 diabetes or even type 1. As a matter of fact, every time she's had her blood sugars tested, they've been normal. But she's so obsessed with it, she's been to the emergency room 6 times in the last 2 weeks because she's afraid that she's having an insulin or a reaction to her diabetes, which she doesn't have. That is a kind of a interesting example because it goes back to what we're talking about, the super users. What we have to do with her is change her thought patterns so she's not rushing off to the emergency room every whip stitch. It's not unusual to see depression and anxiety diagnosed together. As a matter of fact, those of you who are in the medical field know that a number of different antidepressant medications also has an anti-anxiety component to it. Like depression, unlike any other thought pattern, anxiety doesn't really become a problem until it interferes with the daily lives of the individual. Agoraphobia, which will pop up here in a couple slides, is a good example of what I'm talking about. Agoraphobia simply means being afraid of open spaces, okay, but it goes beyond that. Agoraphobia is a particular kind of anxiety where a lot of our anxiety reduction methods don't work because agoraphobia is fear of fear. It sounds kind of strange, but that's why it occurs the way it does, and that's why it's so difficult to break. When somebody has high anxiety or they have an anxiety attack, they begin to lose concentration and attention. And the reason for that is that the individual becomes totally focused on whatever the threat is. Recall when we were way back when we were talking about stress and such, I mentioned that psychic energy is like physical energy. You only have so much in a day to use up. And the brain is constantly redirecting that energy to where it's needed depending on what's going on in the individual's life. So if you get a stimulus overload, what happens is the system starts to break down because the anxiety and the events that are triggering these things are overwhelming. Next slide, please. Anxiety, recall the first session we talked about the progression of mental illness. And anxiety, like the other disorders, can progress and it can get worse. It can develop into phobias, or actually it can start out as a phobia, or it can move to agoraphobia. Okay, phobias are kind of interesting. They're normal fears that get exaggerated to the point at which they are totally irrational with an aversion to something specific. Okay, fear of heights, fear of spiders. Um, a fear of heights is a common fear in humans. At the phobia stage, the individual can become frozen in fear, sometimes to the point of engaging in negative or aversive behaviors. In other words, they make the fear worse. I mentioned agoraphobia. We see more and more of that. Actually, I've seen more of that within the depressive sphere than anything else. When dealing with phobias, we've got a number of methods that we utilize. All these methods deal with creating a behavior plan that challenges or reduces the phobia, often by exposure to the source through visualization and actual experience. I've been paying a lot of attention to this new gadget where you have the virtual reality where you put the phone on these goggles, or you have a machine that's on the goggles. I think you're going to see that being used quite a bit in exposure therapy with anxieties and with phobias, because it's very easy to replicate the fear stimulus with those instruments, as opposed to having the person visualize it in their mind and that type of thing. I would be remiss without telling this story, so bear with me. I have always been afraid of heights. Okay, I used to get dizzy just sitting on a draftsman's stool, just because I don't like heights. Never figured out why, but anyway, I joined the fire department. It was one of the few things my dad had and I had in common. And I joined an engine company specifically so I didn't have to climb ladders. So the first fire we get after I joined was at 3 o'clock in the morning. I got woken up out of a dead sleep. I arrive on the scene. The lieutenant says, "Mason, go up the ladder and vent the roof." Well, my adrenaline was pumping so hard, I went right up the ladder, got up on the roof. I'm chopping a hole, and about halfway through, I'm going, how in the hell am I going to get down? I'm not going back down that ladder. So I walked all the way across, and this was probably more dangerous, as I'm talking about putting yourself in more danger. I ended up walking all the way across the second-story roof to the back of the house where there was a one-story porch roof, and I let myself down off the porch roof. And then I told the lieutenant I couldn't find the ladder because of the smoke. He believed me. So I knew this was going to be a problem. So back home, we responded to calls from our homes. We didn't have crews in the firehouse. And on Sunday mornings, most everybody was in church. There was nobody around. So I would go down to the engine company. I would take the 24-foot extension ladder off the truck. I'd run it up the side of the building, and I would walk up to the point where I was uncomfortable, and then I would stand there, climb back down the ladder, and I would go back up a few more rungs. The idea being that with the exposure, I can be more confident climbing the ladders. Well, I was able to do that, believe it or not. I never had a problem after that climbing a ladder at a fire scene or at fire training or doing EMS rescue. But I got to tell you, I still have the fear of climbing a ladder in a normal situation. Like, I have a very difficult time getting up on the ladder to paint the trim in my house because I'm still afraid of the heights. So you can make some changes. You can challenge the irrational fear, but sometimes it's very situation specific. Next slide, please. As with depression, we have an instrument that we're going to use for a quick assessment, and this is the GAD-7. And this is the short form instrument of choice for evaluating anxiety in a doctor's office. You can also use the PHQ-9 if you're concerned about about the person being depressed. It's a self-report, easily scored by anybody on the staff. It has 7 questions. Anything over a score of 10 requires treatment. A 10 to 15 scores in the yellow zone. In other words, they may need some help. Above 15 is considered a red flag. They definitely need help at that point. The GAD is also effective in identifying panic, social anxiety, as well as PTSD. In the next 2 slides, you're going to find the GAD form for your review. Next slide, please. Keep going. All right. Very simple, Likert scale of 0 to 3, and the rating scale you can see below. It gives you the frequencies of the anxiety and trouble relaxing, being restless, feeling afraid of as if something awful might happen. So we're going to score this sheet, and then next slide, please. At the bottom of the form is another Likert scale, and how much of these problems get in the way. Not at all. Somewhat difficult, very difficult, extremely difficult, and you can go down through the anxieties. Okay. I'm sorry. This below is the scores that I was talking about previously. Okay. And this tells you how much interference. This slide tells you how much interference the individual is experiencing in their everyday life. Because when they're very anxious, it preoccupies everything that they do. Next slide, please. Now, in addition to that, we're going to throw in another logarithm like we did with depression. Okay, they're they're the same. They're the same factors as for depression, other than the agoraphobia. All right, and you can see how this score goes. Clinical presentation, psychotropic drugs not working, suicidal ideation, past treatment, how long in therapy, is depression situational, what's the agoraphobic like? In other words, 1 being mild means that the individual can go out, but they'll alter their schedule to avoid large crowds of people, like shopping at Walmart at 2 o'clock in the morning. Moderate means that the person can function, but sometimes they break down when they're in a large crowd of people. And then severe, they basically are homebound, being severe. They're not going out at all. Next slide, please. Did I miss one?
Yes.
There you go. All right. How do we treat this? Well, it's been very interesting because there's been an explosion of new modalities and statistical evidence to show that the best way to deal with anxieties are not to spend a lot of time talking about them, other than looking for the source, because with a lot of anxieties, there's a source. Recall the diabetic, the woman who's fearful of being a diabetic. Well, her mother went through a diabetic crisis when the woman was 16, and she was home with mom and didn't know how to take care of her. It freaked her out, particularly when mom started having seizures, and that appears to be the source of her current anxiety over the diabetes. Most of the newer approaches are based on cognitive type therapies. Basic, we're trying to restructure thoughts as a method of reducing their anxiety. We're also, like, for example, with RET and CBT, we're also doing a lot of homework assignments. Sometimes, like with an agoraphobic, that's really severe. Okay, your homework for this week is to walk a half block away from home and walk home. I don't care what time it is. If you do it 12:30 at night, that's fine, but I want you to do it every day. And then we'll increase the exposure from there while still challenging irrational thinking. Cognitive behavioral therapy involves a lot of education, practicing, alternative coping skills, and often exposure to the source of anxiety. When we talk about alternate coping skills, one of the common things that happens in an anxiety attack is the patient complains of tingling in their hands and their feet. Well, the reason that is so is because they hyperventilate. They don't realize they hyperventilate. And of course, what happens is then that knocks the oxygen cycle off. So one of the things that you can do is have your patient breathe into a paper bag. And what that does is it increases it decreases the production of oxygen, and they can calm down. Now, of course, you're not going to have patients who want to carry a paper bag around with them and do that in public, but it is one of the alternate coping skills. Another coping skill that I utilize is some visual imagery of teaching the patient how to calm themselves down when they get uptight. The first approach is to get them to modify their breathing, so the breathing is much calmer. And then in their mind, I want them to visualize how best the situation can turn out. Okay, when I was racing cars, I used that a lot on myself. You had what was called a false grid, where you sat in the car before you went out to race. And I would pull my visor down, and I would take deep breaths, and I would literally run the track in my mind. And that caused me to focus and gave me the idea that this is going to be a good outcome. And it worked pretty well, other than when somebody got in my way and I crashed them. But other than that, it worked pretty well. Next slide, please. Didactic behavioral therapy is an interesting therapeutic approach. It was originally developed to treat borderline personality disorders, and the woman who developed it was a borderline personality herself. A lot of re-education's involved with this. There's a workbook that goes along with the treatment. However, some of the skills that are developed in the treatment can be relevant to dealing with anxiety disorders also. The last one that I've listed, and there's probably some more, is eye movement desensitization and reprocessing, EMDR. And what you're doing here, I call this poor man's hypnosis. You're putting the client into a relaxed state, and then you have them visualize in their mind the thing that is creating the anxiety. And when it gets to the point that they can't handle it anymore, they signal you in some way. And the therapist then brings them back down, relaxes them again, and takes them back up. It is fairly effective. I don't utilize it that much. But from the research, it seems like it has some promise. The thing to remember is that all these therapies actively involve the client in the therapy process. And I think that's very important because they're taking an investment and they have a stake in getting well. And what we have to do in therapy, teach them new techniques, new behaviors, and actively challenging their own irrational thought processes. Next slide, please. Okay, Rich.
Thanks, Sean. We're going to move to the next slide, please. Here's what we want to leave you with today. That we know that depression and anxiety and other mental illnesses certainly does impact a patient's ability to manage their disease and participate with your provider in their primary care plan. As I said earlier, the impact on clinical quality outcomes, as well as reducing the total cost of care, is negatively impacted because of the inability and the lack of effort in screening patients for mental illness. So as part of your best practice in your physician office, I would suggest that you choose the screening tools that we've mentioned previously on the last webinar and this one as a best practice model for the treatment and diagnosis of anxiety. And lastly, I would suggest that you give serious consideration to integrating behavioral health into your primary care practice. If you are a CPC plus practice, especially Track 2, you're going to have to look at this more than just as an idea, but as how you're going to implement the requirements called for by CPC plus. And we know that payers are moving toward value-based reimbursement that are also encouraging the integration of behavioral health with per member per month payments and other mechanisms to incentivize the introduction of behavioral health with primary care. Next slide, please. I will leave you with that thought of considering the impact of integrating behavioral health in primary care, the impact of depression and anxiety upon the ability of the patients to understand their disease and reach a state of self-managing their disease. Thanks again for your time and attention.
Thank you.
Thanks, guys. Hey, we do have a couple of questions that have come in, and in the time we've got remaining, let's see if we can hit a couple of them here. One, let me just read it here. Mental health disorders treatment is mostly documented in my practice by the treatment of the symptoms in which the therapist is resolving or reviewing with the patient during that session. So the question is, how would it be better documented to more correlate the symptoms with the illness in which the patient is suffering from?
I'll let Dr. Mason come in after I just say a couple words. One of the things we're working on with the medical advisory group, Simple Practices, is focusing our attention on the high-risk chronic care patient, so that when the provider makes a referral to the behavioral health specialist, that specialist is receiving that referral knowing that that patient has a serious medical condition. It could be an A1C over 9 or whatever it might be. And we want to hone in the treatment modality on that medical issue so that the behavioral health specialist really views themselves as part of the medical team, and they're treating the patient with that medical condition in mind. John, you want to jump in there?
Yeah, I think that you have to look at to me, you have to look at the difference in the emphasis in therapy, okay? You know, in general therapy, you're dealing with the psychological issues. Sometimes they're not even associated with a medical condition. So that changes the way a therapist is going to treat that patient ultimately. With the kind of stuff that we're talking about here, it's a completely different model because we're working with a very specific population. All of them have one thing in common, and that is a physical illness. They are having trouble controlling. That's why they're in that high zone. And so the emphasis in therapy is going to be picking out the roadblocks to them, to their lack of compliance, and folding in how their emotional state impacts that, and then restructuring the cognitive process so that they are more compliant. So it's a lot more focused. I think the way you communicate that is, you particularly if it's a real chronic patient like the one I had yesterday, before I came online, I was already talking to the primary care physician about what I thought about her and what we needed to do in terms of coordinated treatment. And so the communication, I think, between the therapist and the primary care is probably the most important component in this thing in answering that particular question.
Okay, very good. One other question. This goes back to the anxiety screening tools we've been talking about. The question is, what method would you recommend for us to start implementing the use of either PHQ-9 and or the GAD-7?
Well,
I think that where you implement that is right at the beginning during the initial consult with the primary care. You just blend it into, the kind of questioning and however you draw your history. I think that what you do then is you just simply include the GAD or the PHQ-9 based on what you're seeing clinically and what the patient is telling you.
In addition to that, we want to keep it simple, and you might want to include those instruments in your new patient packet that you send out, or if you have electronic registration that your patients can use, and put a little brief note in there with it, why you want the patient, why it's important for them to complete those tools. But in addition, you might want to even slice it just a little bit further, and let's just say you use an algorithm of all of your patients with an A1C of 9 or greater. Start there and use your screening tools, either depression and or the GAD-7 tool, just with that segmented population. Or as I said earlier, those with out-of-control hypertension. The important thing is to find a way to get the instruments in front of the people as efficiently as possible. We know you're busy. We know time is always an issue in a busy physician practice, but these tools will provide the physician a much more complete picture when they're completed than otherwise.
Okay, very good. Thanks a lot, guys. I think that wraps it up for our webinar today. So Dr. John Mason and Richard May, thank you so much for a great overview. I want to remind all of our audience members we'll have the final, the fourth webinar in this behavioral health series coming up on Wednesday, June the 28th at noon Eastern. And Dr. Mason and Richard will get into chronic pain and addiction during that session. We will send the, I think a number of you are already registered for that session, but we'll be sure to include the registration link in our follow-up material, which we expect to send later today. So on behalf of all of us here at Medical Advantage Group, thank you so much for joining us again today. Have a great afternoon, and we look forward to seeing you on the next webinar. Thank you. Bye.
See you later, Rich.
Thanks, Bill. Yeah.
I'll call you later.